Good afternoon to everybody, to the audience. It's a pleasure today to introduce the webinar of the European Society of Gynecology. I am Professor Andrea Giannini from the University of Pisa, and I would like to spend 1 minute talking about the European Society of Gynecology. Is an important society, scientific society, and that cover all the field of gynecological obstetric interest in Europe, and it's a pleasure to present the webinar, and the title is Modern Advances in Gynecological Oncology. This is a very peculiar and important collaboration with the Obstetric and Gynecological Society of Thessaloniki. Indeed, today we will cover the most important aspect of the hot topic in gynecological oncology by three very relevant speakers in the Greek Scientific Society of Obstetric and Gynecology. Professor Daniilidis, Professor Kalogiannidis, and the Assistant Professor Chatzistamatiou. I would like to move on with the presentation of the first speaker. The first speaker is Professor Daniilidis. Professor Daniilidis is a professor in obstetric and gynecology at the University Aristotle at Thessaloniki. And his clinical and academic interest is focused on the endoscopic surgery, reproductive medicine, and quality improvement in clinical and educational practice. He will talk about a very important topic, the Sentinel node modern practice in endometrial cancer. So please, Professor Daniilidis,
I can't hear anything. I don't know if
okay.
I can start. Yes, okay.
Yes, you can start.
Thank you very much, Professor, for this kind introduction. And I would like to say that it's a great honor and pleasure for me to be participating to this joint webinar between the two societies, the European Society of Gynecology and the Obstetrics and Gynecology Society of North Greece. And this type of collaborations are very good and they promise even better future of scientific added value and giving the chance to young colleagues, especially from my country, to get familiar with the European Society and why not becoming members of it. And I would like to say that apart from the fact that I'm being invited by friends, I have nothing to disclose for this presentation, which is about the use of sentinel node in endometrial cancer. And these are the aims of my presentation: to speak what is the sentinel node, why we do it, when and how, in which cases, and what do we expect after that. It's beyond any doubt that the numbers of endometrial cancer are actually increasing worldwide, especially the Western world, because of the pandemic of obesity, also the diabetes, the aging of the population, and the declining hysterectomy rates, and the delays of childbearing bearing of the women. And we do know from facts that about 10 to 15% of supposed early endometrial cancer cases, they will end up to have a metastasis in lymph nodes, and about 10 to 15% deemed to have a GN1 tumors will have a higher grade with the final pathology review. And we do know from vast literature, these are two of the most important randomized trials, which have actually concluded that there's no point to perform a systematic lymphadenectomy in early endometrial cancer in order to improve survival of our patients. And also we do know from hard data that when we have negative pelvic nodes, the chances to have an isolated positive paraortic lymph node is really very small, or almost 1% for endometrioid and about 2.5% for all the other types of endometrial cancer. So the truth about lymphadenectomy is quite clear, that it is very useful in order to stage properly our patients and to take the proper decisions for the further treatment, but it doesn't have any proven therapeutic value. and it doesn't have any positive effect on survival, but it is deteriorating and decreasing morbidity if we perform it without a reason. So here comes the sentinel node. What is it? It is the first lymph node which receives actually the lymphatic drainage and metastasis from the primary tumor. And several techniques have been used in the past in order to achieve the finding of the sentinel node, the blue dye, technetium, the combined technique, and recently, the indocyanine green, the well-known ICG, which is becoming nowadays the standard of care for this type of procedures. Although it's recently been used routinely, it's not so new because we do know that it has been invented a lot of years ago. It has been used by Kodak for photography. It's been used by the ophthalmologists for years for retinal angiography. And the principles are very easy and clear. We do the injection of the ICG. It binds to the plasma proteins. We have the excitation of the ICG fluorescence with the near-infrared red light, and we detected the signal with the special endoscopes. And then we evaluate the signal. This is one of the first studies which has actually compared the old technique, the combination of blue plus technetium and the ICG. It was a multi-center study, and showed that if we use the ICG in order to find the sentinel node for early stage endometrial cancer, then the detection rate will be significantly higher than using the older technique. And this is a randomized study, a large one with about 180 women. And here authors randomized patients. In half of them, they have injected first the blue, and then they injected the green. In the other half, they have injected green, the ICG, and then blue. And they found that when they were using the ICG, the detection rate of bilateral lymph nodes was significantly higher. The ICG identified all metastatic nodes. There was no improvement to the outcome if ICG was combined with blue. And of course, there were no allergic reactions or adverse events. That means that this type of technique is quite safe for our patients. And this is another randomized trial, a recent one, which in this case, authors randomize the sides, the pelvic sides of the patients. In one side, they have injected blue on the cervix, and the other side of the cervix, they have injected ICG. For the sides of the same patient that ICG was used during the laparoscopy or the robotic surgery, a higher number of lymph nodes were detected and isolated. And what is fundamental with the concept of the sentinel node is that instead of giving 30 to 40 lymph nodes to our pathologists, we give one or two. That gives them the advantage to perform ultra staging. That means to perform 40, 50 cuts to the lymph node and examine closer with a cytokeratin stain, and to find micrometastasis of 0.2 to 2 millimeters or even isolated tumor cells, which is quite important for the staging. And this has been shown actually by Kim and his colleagues a few years ago, that by using the ultra staging, then even for early stages of endometrial cancer of no invasion, we will detect almost 5% more cases. And if we add in this the isolated tumor cells, this will go up to 8%. This is one of the fundamental trials, the first trial, which was a multi-center prospective cohort study comparing the sentinel node versus routine lymphadenectomy. And in this study, authors demonstrated that out of the 36 patients positive for lymph nodes, 35 were detected with a technique of sentinel node. That gave 97% sensitivity and a negative predictive value of almost 99.6%. And also as for the oncological safety, if it's measured with blood loss, operating time, post-operative complications, and recurrence-free survival interval, this study with a large number of patients comparing technique of just performing performing hysterectomy with routinely removal of the lymph nodes, and hysterectomy with sentinel node showed that outcomes were better if we perform hysterectomy with a sentinel node technique. And meta-analysis about the recurrence rates of the disease and the nodal recurrence rates demonstrated that there was no difference between the routine lymphadenectomy and the sentinel node mapping. But what happens with the high-risk endometrial cancer cases? This is one of the first studies, a retrospective one with a lot of patients, 240 almost, with high-risk endometrial cancer, comparing lymphadenectomy versus sentinel node again. And the overall survival for these patients with an average of 31 months follow-up was the same. There was no difference between the two techniques. And actually, the technique of injecting the ICG is quite simple. Recently, we just inject in two sides, 2, 3, and 9 o'clock of the diluted ICG in sterile water, 1 ml superficially and 1 deeply. And the best dosage is just 2 ml from each side. We don't need to use a higher dose because it's not going to increase the rate. And the best site is to inject it on the cervix and not on the fundus, as it has been shown by several studies like this randomized trial where authors injected with the use of hysteroscopy in the fundus of the uterus. But then after we inject the ICG, we have to isolate and remove the sentinel node. And we have to know actually what we are removing. And it's fundamental to realize that our scope is not to show how good surgeons we are and to remove everything we see, but to provide quality and not quantity. That means that we should be able to open the spaces properly, the pararectal and the paravesical space, following the obliterated artery, and trying to follow the mapping of the lymph nodes in order to detect and then isolate and remove the sentinel node. In most of the cases, almost 95% of the cases, this sentinel node will appear in the pararectal space between the uterus, the ureter and the big vessels, and only in 5% of the cases will be isolated in the presacral area. So it's fundamental to detect it and to know what we are actually removing. In some cases, although it is obvious by the technique that we see the lymph nodes, we see an enlarged lymph node which is not picking up the color. This lymph node has to be removed. Usually we are talking about metastatic lymph nodes, and there is a blockage of the lymphatic channel. In these cases, when we don't have proper mapping of the lymph node, of course we have to remove all large lymph nodes, but we have, according to the guidelines, to perform from this side a total pelvic lymphadenectomy in order to be sure that we have removed the lymph nodes, the lymph node that we are looking for, and we'll be able to perform a proper staging for our patient. And this applies for all types of endometrial cancer. As for the safety of the use of the sentinel lymph node, even for high-grade endometrial cancer, central study was fundamental. 156 patients, or most of them with a high-grade endometrial cancer. Out of the 27 patients with nodal metastasis, 26 cases were picked up with lymph node technique that gave a sensitivity of 96% and a false negative rate of only 4% with a negative predictive value of 99%. So only one patient was misclassified by using the sentinel lymph node algorithm. Similar results with the STREC trial for high-risk, again, endometrial cancer cases. This was a prospective study with almost 260 patients, half of them with high-grade endometrial cancer, and authors had a bilateral detection of sentinel lymph nodes in 95% of cases, and the sensitivity was 100%, and negative predictive value of the algorithm was 100%. But you will hear again and again about the algorithm of sentinel node mapping. What is that? Mainly is the first thing is the proper technique as it has been shown, but then the proper assessment of the case. That means that it doesn't, we shouldn't remove only the lymph node we detect with the ICG in case that there are other suspicious elements like enlarged lymph nodes. They should be removed too. If preoperatively the PET or the CT is demonstrating a positive lymph node, we have to remove that too. And of course, if we fail to detect the sentinel lymph node, then we should perform from this side a total pelvic lymphadenectomy. This is the proper adherence to the sentinel node algorithm, and this is going to give us a sensitivity of more than 95% if we follow the proper technique. And all actually big societies, the American Society, the Society of Gynaecological Oncology, ESGO, the British Society, and the Japanese society, they do agree that sentinel lymph node is an appropriate alternative to pelvic lymphadenectomy for uterine confined endometrial cancer. Full lymphadenectomy should be performed only in cases when we fail to perform a sentinel lymph node mapping. We should use indocyanine green, which is superior to other methods. We should inject to the cervix. And of course, we should perform ultrastaging. There's no consensus still between the societies for the high-risk patients of sentinel lymph node as a sole method of staging, or for periodic lymph node evaluation in case we have positive sentinel lymph node patients. Let's see what ESGO says. If we go to the pocket guidelines, systematic lymphadenectomy is not recommended in low and intermediate risk patients. Sentinel lymph node can be considered for staging in the low and intermediate risk patient. It can be omitted when there's no myometrial invasion. Cervical lymph node staging should be performed in patients with high grade and intermediate risk disease. And sentinel lymph node is an alternative acceptable for patients of high and intermediate risk. Site-specific lymphadenectomy full should be performed when sentinel node is not identified in high and intermediate risk patients, and sentinel node should be performed with ICG cervical injection. And the most recent consensus in the ESCO Congress that we should prefer the minimally invasive technique, that is laparoscopy or robotic surgery, endocyanine herein, systematic lymphadenectomy when we fail to find the sentinel lymph node. But the most important, that the technique of the sentinel lymph node biopsy should be performed for staging procedures of all patients with presumed uterus confined disease. That means also for the high risk cases. That means that sentinel node now is the gold standard technique in order to identify and stage properly our patients with endometrial cancer. And if we want to see what happens with molecular subgroups which have entered in our lives and are giving us the opportunity to stage properly and better our patients, this is a nice retrospective cohort trying to combine this molecular subgroup results with the sentinel node identification, and it seems that the sentinel node macrometastases are associated with higher risk of recurrence in the entire cohort group. P53 shows the highest rate of sentinel lymph node macrometastasis, and MMRD, endometrial cancer, with sentinel node macrometastasis are an independent predictor of recurrence and disease-specific death for these patients. And about the question whether we should perform routinely for cases with atypical endometrial hyperplasia, sentinel node, since in 20 to 30% of these cases we shall have endometrial cancer by the final pathology. This meta-analysis gave the answer that less than 2% of these cases will actually have a positive lymph node metastasis, so it's not advocated to be performed routinely when we just have atypical endometrial hyperplasia. And of course, we have evolution, we have technology, we are trying to become better in order to be able to detect the sentinel lymph node. This is a nice proposal with the use of image-guided ultrasound during the robotic procedure in order to identify the sentinel lymph node. So as a take-home message, I would like to say that Sentinel lymph node in endometrial cancer optimizes additional treatments for our patients and allows the step from a minimal invasive surgery to minimalized surgery. With this, I would like to thank you all for listening to me, and I would like to say again thanks and to congratulate both societies, the European Society of Gynecology and the Society of Obstetrics and Gynecology of North Greece for this great collaboration. Thank you very much.
Very, very good presentation. Thank you. On time. This is a very hot topic. I think there will be a lot of questions at the end of the three presentations. So I would like to remember to the audience that at the end of the third presentation, we will have relevant part of a Q&A. So please sign and send us the question. So thank you again, Professor Daniilidis.
Thank you very much, Professor.
And we move on with the second speaker, Professor Professor Ioannis Kalogiannidis. Professor Kalogiannidis is a professor of obstetric and gynecology and gynecological oncology at the Aristotle University of Thessaloniki. He is the director of the SGO training program in gynecological oncology. And so he will talk about the early stage cervical cancer and developments in fertility practice. Welcome, Professor Kalogiannidis, please.
Thank you very much, Professor Giannini, for the introduction. I think that you can hear me, isn't it? Okay?
Yes.
Okay, perfect. First of all, I would like to thank you one more time, the European Society of Gynecology, of this kind invitation to participate, to organize, together with Society of Obstetric Gynecology of Thessaloniki, this webinar related to modern advances in gynecological oncology. And very fast, I'm moving on my speech, which is the early stage of cervical cancer, and of course, the developments in fertility practice. Well, there is no conflict of interest in my presentation. And yes, it is true and remains true that the cervical cancer, it is one of the most common cancers on the female population. As you can see here, according to the estimated number of new cases of WHO, you can see that the cervical cancer, it is the fourth more common cancer in female population. And as you can realize, the 2/3, the 70% actually of this patient, it is the age of less than 60 years old. And from this rate, again, 70% is of the reproductive age. So almost the half of the patient with cervical cancer will be patients of reproductive age. And this is the figure staging concerning the last figure staging concerning the cervical cancer. And this stage that are in blocks are the stage in which it can be we can be conservative. Mainly stage 1A1, 1A2 and B1. And there is a little bit of debate concerning the stage 1B2. However, apart from the figure staging, there is another classification very important, which it is very important, very critical to have in mind, which is the risk group of every patient with cervical cancer. And as you can see here, we have three different groups, as we have as well as in endometrial cancer, which is the low, intermediate, and high risk. And you can realize that the patient which have a tumor of less than 2 centimeters with lymphovascular involvement negative and the stromal invasion of less than 1/3, it is the more pretty good group of patients which we would like to be treated. And of course, this group can be treated conservatively, actually, to remain the uterus in situ. High risk, of course, a patient with more than 2 centimeters with positive lymphovascular involvement and any type of stromal invasion is not a group of patients which is good candidate for a fertility presentation, while the intermediate risk, it is cases in which the debate is ongoing. Now let's start with the stage which is the most easy to be practiced in fertility practice, which is the micro-invasion cervical cancer, the stage 1A1. And as you can see, you can realize from this table, the overall, it is a nice practice to be fertility sparing in these cases. It is because the overall recurrence rate for this patient, it is, as you can realize, less than the 0.5%. And the rate of pelvic nodes is only 0.5%, while para-aortic nodes there is not B in this stage. The traditional treatment for these cases, as you can realize, it is the simple hysterectomy with or without the ovaries in case of patients that they don't want the fertility, they don't desire the fertility presentation, or because they don't want to have after the operation a close follow-up related to the microinvasive cervical cancer. However, on the other hand, there is the conservative approach, which is excideconization or the loop for patients who desire to the fertility presentation. And of course, the ESG gave us this last update of 2023 concerning the conservative approach of this patient. And as you can realize here, the treatment approach, it can be conization or simple trachelectomy in selected cases. And in cases that we have negative lymphovascular involvement, it is not necessary to perform staging concerning the nodes, the pelvic nodes of this group of patients. Similarly, the NCCN, the USA, give similar guidelines concerning the conservative approach of these cases, which is also conization for stage 1A1 with no lymphovascular involvement. However, as you can realize, in case that we have the same stage, however, with positive lymphovascular involvement, the management, it is not the simple trachelectomy as in Europe, but the radical trachelectomy. This is the main difference between the two main groups of who organize the guidelines of gynecological oncology. Radical trachelectomy for the USA, for the NCCN, while simple trachelectomy for the Europe. We are moving on the other stages, which is the 1A2 and 1B1, actually tumor not more than 2 centimeters. And as you can see, the overall recurrence in these cases after treatment is for the stage 1A2, 4%, and for 1B1, 10%. The traditional approach, it was the radical hysterectomy with lymphadenectomy for this group of patients, for these stages. And of course, this is the two iconic figures who gave us the guidelines, the base of gynecological oncology, and the way which we can treat this group of patients. It is the Wertheim, which almost at the end of the 19th century gave the technique of the radical hysterectomy. And as you can realize, at that era, the operative mortality of this operation, it was almost 20%. It was needed almost 50 years at the 20th century, in which gave us a pretty nice operative mortality rate, less than 1%. After that, thereafter, there was many classification concerning the radical hysterectomy. However, the most popular, it was the classification of radical hysterectomy given by Piver, and thereafter from Kerle, which is the current, let's say, classification of radical hysterectomy that we use in Europe. To be more clear, concerning the Piver2, it is similar with type B1, B2, and the Piver3, of course, with type C1 and C2, which is dependent, of course, the radicality, as you can realize, of the radicality of extraction of the ventral, lateral, and dorsal parametrium of hysterectomy. According to the last update of the ESG concerning the guidelines of the treatment of the management of cervical cancer, there was something different concerning the previous guidelines, and this different, it was related with the stage 1A2, in which we can be less radical. Actually, patients with stage 1A2 can be treated safely with simple hysterectomy, of course, with exploration of retroperitoneal area with sentinel node biopsy, and in case that was negative, of course, to proceed with systematic lymphadenectomy. So the difference with previous guidelines, it is the same concerning the radical hysterectomy. However, for the stage 1A2, the simple hysterectomy can be easily approached for this group of patients. Another treatment, of course, which must be noted, it is also for these stages of cervical cancer, the radiotherapy, and with or without chemotherapy. And according to many trials, and this is maybe the most critical, which is randomized trial, show that the overall survival and disease-free survival, comparing the radical hysterectomy versus radiotherapy, give the same results, the same rates concerning the prognosis of this patient. And let's speak the main part of this presentation, which is the conservative approach of these stages. Concerning the conservative approach for stage 1A to 1B1, as you can see, there are 4 different approaches: the radical vaginal trachelectomy, radical abdominal trachelectomy, simple trachelectomy, and conization. And this is, of course, another iconic man, not other than Daniel Dazan, who introduced this conservative approach for patients of these stages. Actually, Dazan in 1994 gave us the roles of this approach, the roles of this game. It is necessary to not have a severe subfertility for going on with a conservative approach for this patient. We can use the conservative approach, actually the vaginal radical trachelectomy, for any histological type, squamous as well as adenocarcinoma. The tumor must be less than 2 centimeters, the stromal invasion less than 10 millimeters. It is actually very important to be lymphovascular involvement negative and free the upper part of the vagina, and of course free nodes. We have included all these rules in the conservative approach because, as you can see, after all these rules, the possibility, the probability of positive parametrial involvement, it is less than 1%. And of course, this rule give the permission to proceed in the conservative approach of patients with cervical cancer. This is some of the results concerning this approach, vaginal trachelectomy. And as you can see, the recurrence rate, it is less than 3%. Live birth rate after vaginal radical trachelectomy, it is almost 50%. However, the prematurity, less of 32 weeks, it is almost the 1/4, actually 25% of patients who have treated with vaginal radical trachelectomy. On the other part of the Atlantic, in the USA, you can see 10 years after from the MD Anderson, from the Memorial Hospital of New York, it's come another approach concerning the same group of patients with same stages, which is the radical abdominal trachelectomy, of course, with previous pelvic negative lymphadenectomy. It is the abdominal trachelectomy who gave us the same results, the same the feasibility and the safety of this approach as the technique of Daniel Tarzan. A little bit later, they come this trial from Canada, from Marie Planté, in which he gave similar results with the procedure named simple trachelectomy plus pelvic lymphadenectomy, of course, for the same group of patients. As you can realize, crossing the time, the radicality, it become less and less uh, radical approach for this group of patients. And of course, during, as you can realize from this table, all this period with all this procedure of radical trachelectomy, simple trachelectomy, etc., at the same time, there was also even more less radical operation, actually conization or cold knife or less or laser. And as you can see, the recurrence rate of all these patients was pretty good, less than 2% with the approach of conization, always for the same group of patients of the same stage. Nowadays, we have very clear and very robust data, who has given from ESGO in the update of 2023. And as you can realize, we can use all this less radical approach, the conservative approach for patients with squamous or adenocarcinoma. Of course, the basic rule, it is negative lymph node and the tumor of less than 2 centimeters. In this group of patients, of course, we can be conservative. And actually, for stage 1A2, the treatment approach after the surgical confirmation that the nodes are negative, we can use the approach, the treatment of conization or simple trachelectomy. Similarly, the NCCN guidelines give the same approach for the same stage, conization, and of course the exploration of the retroperitoneal space with the sentinel mapping and pelvic lymphadenectomy. However, in case in which we have 1A2 with lymphovascular involvement, as we have seen previously, for stage 1A1 for microinvasive carcinoma, the approach must be the radical trachelectomy and not the simple trachelectomy as we perform in Europe. Of course, the approach of retroperitoneal space remains the same. For stage 1B1 with negative lymphovascular involvement, you can see in all these slides how critical is the termination of the lymphovascular involvement. So, in case of this stage with a negative lymphovascular involvement, similarly with the previous, the treatment can be conization or simple trachelectomy after, of course, the intraoperative staging of pelvic nodes. However, radical trachelectomy is still an option in case that the tumor it is near or behind the 2 centimeter, or maybe in which the involvement of stroma it is more than usual. Concerning the stage 1B1 with a positive lymphovascular involvement, the treatment, of course, it is the radical trachelectomy. However, in case that we don't have very deep stromal involvement, and in case that we have a not very high tumor, very gross volume of endocervical tumor, we can perform also in this group of patients the simple trachelectomy, of course, after the exploration of the the pelvic nodes, and in case, of course, that it is negative, because in all these exploration, when the nodes are positive, we stop all this procedure, and of course, with this patient is not good candidate for fertility presentation. Similarly, the USA give the same guidelines for the stage 1B1 and negative lymphovascular involvement, in which the conization and the exploration remain the same as in Europe. However, for the stage 1B1 with positive lymphovascular involvement, in this case, of course, the approach, it will be the radical trachelectomy. As you can realize, there is no simple trachelectomy for the USA for the approach of this group of patients, or conization or radical trachelectomy. And we are moving on the conservative approach for stage 1B2, which is actually the patient with tumor between 2 and 4 centimeters, which is a group of patients which is in debate. And this is a very, very critical paper trial who gave to us from, again, for Maria Plante. And we have two-arm approach for this patient. And as you can realize, the first approach, the first arm is the radical trachelectomy, the upfront radical trachelectomy. And the recurrence rate for this group of patients is only 4%. However, the pregnancy rate, it is only 4%, 40%, and the third pregnancy, it is the 37% of this 40% with pregnancy rate. On the other hand, for group of patients that we can use neoadjuvant chemotherapy, and thereafter to proceed with simple or radical trachelectomy. And as you can realize, the recurrence of this group of patients is higher than the previous one, 7% compared to 4% of the previous arm. However, the pregnancy rate is almost more than 100%, and the pregnancy rate is almost 40% of this 100% of pregnancy rate, giving actually more higher percent of live births in this group of patients, of course, with higher recurrence rates using the neoadjuvant chemotherapy. And this is a very nice trial who has given to us from Philip Morris from France, who have enclosed more than 700 patients in the period from 87 to 21. And as you can realize, the recurrence rate after chemotherapy, it is and thereafter, of course, with simple or radical trachelectomy, have a pretty high recurrence rate, almost 13%, while the recurrence rate for patients who have treated with radical trachelectomy, it is only 5%. Actually, it is 3 times more in a group of neoadjuvant chemotherapy. However, the pregnancy rate, you can realize it is very high concerning the cases who have treated with the upfront radical trachelectomy. Actually, 74% of pregnancy rate compared with 36, which is very important because, as you can realize, the point in this group of patients, it is the pregnancy. And this is the last update of ESG, who gave clear guidelines in which we can be fertility sparing for patients with cervical cancer with tumor of less than 2 centimeters. In case of tumor between 2 and 4 centimeters, of course, can be considered the fertility sparing treatment. However, it must be discussed with the patient. the different prognosis which we have after radical trachelectomy or neoadjuvant and simple or radical trachelectomy thereafter, however, with different rates of pregnancy rates and live birth. However, and at the end, for the tumor of more than 4 centimeter, actually the stage 1B3, there is not discussion for excuse me, for fertility presentation. And finally, this is my final slide, and this is the take-home message. The patient must be informed for the tumor, for the treatment which must be given, and there must be clear patient consultation concerning the prognosis and, of course, the rates of live birth. In case of microinvasive carcinoma and with lymphovascular involvement negative, it is a very nice, a very perfect treatment for this patient. However, for patients with stage 1A1 with positive lymphovascular involvement and 1B1, we can use one of these treatment, common simple trachelectomy or radical trachelectomy. However, the precondition of Sentinel node or the lymphadenectomy must be negative. The retroperitoneal space must be clear of metastasis. And finally, for the stage 1B1, B2, sorry, in case that it is the nodes negative, there are two treatment approaches. One, it is the upfront radical trachelectomy versus neoadjuvant chemotherapy and trachelectomy. And with this slide, thank you very much for your attention.
Thank you, Professor Kalogiannidis. It's a very relevant presentation. This is, in my opinion, the perfect example of precision and personalized medicine in gynecological oncology. And I would like to spend a few seconds. It's mandatory to perform this kind of counseling in tertiary referral center for gynecological oncology because these cases are rare, and it is important to approach the patient with a very huge expertise and knowledge about the current guidelines. So it's important to the tertiary referral center. Thank you so much for the moment, and move on with the third speaker. The third speaker is the assistant professor Kimon Chatzistamatiou. He is an assistant professor of obstetric and gynecology at the Aristotle University of Thessaloniki. He is a clinical fellow in gynecological oncology. Moreover, he is on the board of the Hellenic HPV Society and the International Papillomavirus Society. He will talk about another very interesting topic, the frontiers of a conservative approach of borderline tumors. So move on with the presentation on the adnexa pathology. Please, Professor Chatzistamatiou.
Thank you, Professor Giannini, for the wonderful introduction, and many thanks to the European Society of Gynecology and the Obstetrical and Gynecological Society of Thessaloniki for the kind invitation to me to participate in this webinar. So my talk is about frontiers of conservative treatment for borderline ovarian tumors. Now I will try to give you the big picture behind the borderline ovarian tumors and the general idea, so that it can be clear why we're talking about this topic. Why do we need frontiers in surgical management of those tumors? And what enables us actually to consider less radical approach for this kind of tumors. Now, those tumors were first described by Taylor in 1929 as a subset of epithelial ovarian tumors, and it was until 1970s that they were characterized actually as borderline ovarian tumors, meaning that they have a malignant potential somewhere between benign and actually malignant. Those tumors consist 10 to 20% of all ovarian epithelial tumors, and they are actually quite rare because their incidence ranges between 1.8 to 4.8 per 100,000 women per year. The thing is that the most important thing is that 1/3 of the patients with a borderline tumor are younger than 40 years, and we will talk about it in more detail later. The histological classification of borderline ovarian tumors is that of the WHO of 2020. There have been some changes between since the previous histological classification in 2014. And the most important one, or the most important of those changes, is that we need to take under consideration the nature of implants. In 2014, we talked about borderline ovarian tumors with invasive implants or with non-invasive implants. And by the word implants, actually, we mean tumor outside the ovary. We'll talk about it in detail later. So the important thing for now is to know that when we talk about invasive implants, we actually don't talk about borderline ovarian tumors at this point. We talk about another disease, about the extra-ovarian low-grade serous carcinoma. So this won't be, as we will see, a topic of my talk. Now, we usually have serous borderline tumors. Those are 50 to 55% of the overall borderline tumors. We have mucinous tumors, 35 to 45% of those tumors. And we have other rarer subtypes, seromucinous, endometrioid, clear cell, and borderline. Now, regarding the implants, we have those are lesions which develop outside the ovary. Those implants are seen in about 30% of serous borderline tumors, and they can be invasive or non-invasive. Now, non-invasive means that they do not invade the underlying peritoneal surface, and invasive are associated to low-grade serous carcinoma. Now, the important thing to know is that the distinction between those implants is done in pathology, in the pathology lab. We cannot do it otherwise. So, regarding ovarian cancer carcinogenesis, we have actually now two types, which consist two different entities. And this is a pattern that we can see in quite a few types of cancers, and also in ovarian cancer. So the most common type of ovarian cancer is type 2, actually, which includes high-grade tumors which develop rapidly. This is the usual type of ovarian cancer that we encounter, and we do not know any we do not have any solid precursor for these types of cancers. However, we have type 1 carcinogenesis in ovarian cancer, which is about low-grade tumors which develop slowly and follow a certain pattern, developing from benign to borderline and then to malignant lesions. So serous borderline tumors develop from a cystadenoma, and there might be a progression to a low-grade serous carcinoma. Mucinous borderline tumors also may be related to a cystadenoma or sometimes to endometriosis, and they could progress to intraepithelial carcinoma and then to mucinous carcinoma of the ovary. And we can see that we have certain types of mutations in those cases. And of course, we have other rarer types like endometrioid or clear cell, which could be associated with endometriosis. And this does not actually mean that endometriosis is a precursor for cancer, but there is an association. And those types can progress to intraepithelial carcinoma and then to low-grade endometrioid carcinoma. And they are associated to different types of mutations. Now, why are borderline tumors so important, and why do we discuss of them so much? We will see that in the next two slides. Here we can see the epidemiology of borderline ovarian tumors. This is a global pattern, more or less. But these graphs come from a study in Korea where they investigated more than 5,000 women with borderline ovarian tumors. So we can see that those tumors are very common, are commonest between 30 and 45 years of age. And if we combine this fact to the fact that the median age of a woman at first birth is being gradually increased during the past decade, so we can understand why this topic is so important in terms of preserving fertility. And of course, we have been noticing during the past decades that that there is an annual increase in borderline ovarian tumors incidence. So women give birth later in life, and borderline ovarian tumors, which require surgery on the ovaries, which might impair fertility, occur earlier in life. So the concerns in borderline ovarian tumors are mainly the ones referring to fertility sparing, but also we should never forget that apart from fertility, there are other concerns for women who might not be willing to have children, for example, for any reason. We should always keep in mind that ovarian surgery might lead to early menopause. So it is not only about fertility, but it's about the general health of women. So early menopause, we should not forget that is associated to cardiovascular disease, osteoporosis, metabolic disorders, genitourinary atrophy, sexual dysfunction, lower quality of life, cognitive impairment, and so forth. So this poses concerns about how should we approach the uterus and the ovaries surgically in terms of borderline ovarian tumors. And of course, we always need to keep in mind that these are tumors which have a malignant potential and lie somewhere between benign and malignant, but there is a malignant potential. So we have to be certain that we treat women with fair oncological safety. So we have to keep a balance between fertility sparing surgery and oncological safety. If we are more radical in surgery, we can have better oncological safety, but we impair fertility, and the opposite the opposite happens in case of the opposite. So if we need to preserve fertility, we might compromise oncological safety. So our aim is to enable patients to have unassisted or assisted pregnancies when we treat them for borderline ovarian tumors, so that they can keep their uterus and maybe their own oocytes. And this can be achieved with collaboration between healthcare providers, with collaboration particularly within an MDT board, a multidisciplinary tumor board, where there is a gynecological oncologist, medical oncologist, other specialties, and there should be also a reproduction medicine specialist. And the thing that enables us to talk about less radical surgery in borderline ovarian tumors is the prognosis of those tumors. And this prognosis is excellent. As we can see here, in very early stages of borderline ovarian tumor, stage 1 or stage 2, 5-year overall survival is above 95% or above 98%. And even in advanced stages of borderline ovarian tumors, 3 and 4, 5-year survival is still quite high. There's no comparison to the high-grade serous carcinomas of the ovaries, as we can see here. And another important thing is that usually borderline ovarian tumors can progress to certain types of cancers. So serous borderline ovarian tumors can progress to more often progress to serous ovarian cancer, and mucinous more often progress to mucinous borderline ovarian tumors. And the thing is that usually the recurrence or the malignant transformation occurs within earlier during the follow-up period. So we need to have a strict follow-up period after initial surgery, and particularly women who wish to preserve fertility, as we will see later, need to take quick decisions about their fertility after initial surgery, staging surgery for borderline ovarian cancer. Regarding staging, we use the staging system by FIGO. More often, the staging system is the same for epithelial ovarian cancer. So we have stage 1A, stage 1 when the tumor is confined to the ovaries. We need to pay particular attention to stage 1C. We can see here that 1C1 is surgical spill, so be careful when you treat surgically those tumors, because you might upstage a disease from 1A to 1C if there is a rupture. We have stage 2, where the tumor involves both ovaries and fallopian tubes, and there is pelvic extension. Stage 3, where we have extension, macroscopic or microscopic extension beyond the pelvis. And of course, we have stage 4, where we have distant metastasis. Now, surgical procedures in borderline ovarian tumors usually include adnexectomy, cystectomy, hysterectomy, or single or double adnexectomy. And we need to keep in mind that there are certain procedures that we need to perform in order to stage women properly, which are cytological evaluation of the peritoneal cavity, omentectomy, peritoneal biopsies, and in selected cases, particularly in mucinous borderline ovarian tumors, we need to also consider appendectomy. Now, those procedures have been very clearly stated and taught by ESGO, the European Society of Gynaecological Oncology, which dictates that we can use either the open route or minimally invasive approaches for the management and the staging of borderline ovarian tumors. The standard is a unilateral salpingo-oophorectomy or bilateral salpingo-oophorectomy. And in case of fertility sparing surgery, we can opt for cystectomy, ovarian cystectomy, and this is acceptable. We need to avoid the rupture of the tumor, and we need, as I said before, to perform accurate staging, because this is important for the prognosis, and this is important to make us opt for fertility sparing surgery. Fertility sparing surgery is about preserving either the uterus or part of one ovary at least, so that the woman can have children with her own oocytes, if that is possible, of course. And if not, we just need to preserve the uterus in order for the woman to use assisted reproductive technologies and donor and oocytes from a donor. And also, we need to consider the age of the woman when we're talking about less radical surgery. It is not, I mean, it's not logical to consider less radical surgery when we talk about women in menopause. Okay, this is logical. In case of menopause, we need to do bilateral salpingo-oophorectomy when we have borderline ovarian tumors. However, those tumors, we said previously, in any stage, there are oncological criteria which permit fertility sparing in any stage, either early or advanced stage. And those criteria have been recently published last year by the ESGO, by the European Society of Gynaecological Oncology, and the primary investigator of those guidelines was Philip Maurice. And of course, our department here in Thessaloniki in Greece has contributed to those guidelines with our gynecological oncologist head, Professor Dimitrios Tsolakidis. And the recommendations of those guidelines are actually divided in certain categories. The general recommendation is that if bilateral oophorectomy is needed in order to permit fertility sparing, we need to perform uterine sparing surgery, as I said previously. We can do bilateral ovarian cystectomy or unilateral salpingo-oophorectomy and cystectomy, but we have to keep in mind that cystectomy is associated to a 30% recurrence of a borderline ovarian tumor. So this recurrence does not affect the overall survivor. So we have to notify the women of this, but there is a risk of recurrence. So we have a reduced disease-free progression we have a reduced time to first recurrence in that case. If the woman is not able to achieve spontaneous pregnancy, ovarian stimulation followed by oocyte retrieval is an option either in early or late stage borderline ovarian tumors, and it is not contraindicated, I mean, but this needs to be done only when for late stage, only when we have a concrete result regarding the stage of the disease. So we need to have performed a very accurate surgical staging in order to actually mean it when we have stage 1, 2, 3, or 4. Another important thing is that we need to consider what happens in case of recurrence of a borderline ovarian tumor. In case of recurrence, still we can perform fertility sparing surgery, either in recurrence, I mean the first recurrence, but in that case, we need to very clearly consider fertility evaluation for those women, because fertility, because for women who are not able to get pregnant spontaneously, we need to very quickly refer them to reproductive specialists for assisted reproductive for the implementation of assisted reproductive techniques. And that, of course, is something that needs to be done very quickly after fertility sparing surgery. So we need to keep the women alert so that they don't lose time after initial surgery and after staging surgery, so that they can get pregnant. Now, another frontier regarding surgery for borderline ovarian tumors is hysterectomy in postmenopausal women. So in those women, we do not talk about fertility sparing surgery, but there is an issue regarding hysterectomy. I mean, the disease is on the adnexa, so we have been always considering whether hysterectomy is necessary or not. And the international guidelines do not align with each other. So the American guidelines say that we should perform hysterectomy. The British guidelines that we should not, the French that we should do it only when we have endometrioid histology, and the ESG guidelines say that we should do it on a case-by-case decision, on a case-by-case basis. So there is a study, a very recent study, published a few months ago from Italy, a multi-center cohort study, a retrospective, of course, from 2005, including women treated with borderline ovarian tumors from 2005 to 2015. And they included 483 women. And they saw that there is actually a protective effect of hysterectomy in disease-free survival. So women with borderline who are post-menopausal should maybe be offered hysterectomy, because this does not have an effect on overall survival, but it could increase disease-free survival. And the interpretation of this effect is not fully understood, but there is a possible cytoreductive role of hysterectomy, which might be explained because of the removal of the peritoneum, which is lining the uterus. Now, what about the future? Actually, now we do not have, apart from staging and all the other parameters that we should consider, we do not have other solid tests which can guide us through a risk stratification of women in terms of possible recurrence after a borderline ovarian tumor. However, in the future, there are studies and there are biomarkers which might be useful, which might prove useful in the future for this risk stratification, which is something very important. Now, as a conclusion, we should say that we can say that conservative management in borderline ovarian tumors is feasible only when we have performed a complete staging and when appropriate selection criteria of the patients are met. It is very important to have a multidisciplinary tumor board and a multidisciplinary team approach in the management of those women. And we have to ensure that those women will be followed up closely, because otherwise we cannot suggest fertility sparing surgery. Now, recent advances include novel imaging modalities, include minimally invasive surgical techniques, integrated fertility preservation strategies, and one of the most important things would be improved risk stratification tools, which could be biomarkers, which will be used in the future. Also, in the future, we should expect to have a more personalized approach managing those tumors, integrating imaging, biomarkers, and quality life optimization. And with that, I thank you again for the invitation to participate in this webinar.
Oh, thank you so much, Professor Chatzistamatiou, for this state of the art about the most important aspect of the modern approach to borderline tumors, about the conservative treatment. So we have 15 minutes for discussion, for Q&A, and I would like to remember to the audience that feel free to write their question in the chat for Q&A, and I will read the question to our great speakers. So I would like to start with the question for Professor Daniilidis. So thank you again for the presentation. It was comprehensive and clear, but I would like to send a take-home message for the young surgeon. So which are the best technique, giving the data of the literature, which are the best technique for the detection of sentinel lymph node, and what about obese patient, because we know that obese are peculiar and sometimes give us some challenging surgical task. Please.
Yes, thank you very much, Professor, again. It's obvious that we are evolving and that we're trying to become better for the safety of our patients to provide them the best cure with the least recurrence rate and the best outcome for the quality of their life. As regarding for my presentation, the Sentinel note, it seems that this new approach with the ICG and the injection in two sites on the cervix, it's the best way to introduce the fluorescent skin in order to detect the sentinel node. Of course, as all guidelines propose, and it is obvious not only for morbidity, but also technically, endoscopic surgery is the best approach to treat endometrial cancer nowadays. Whatever the situation, especially when the pathology is confined in the uterus, because of the minimal morbidity and the ability we have with the cameras to have magnification, etc. Especially for obese cases, because we're talking about endometrial cancer, so most of the patients will be obviously obese. Endoscopic approach is the best one, either laparoscopic or robotic if it's feasible and it's available, because it will be easier for the surgeon also to perform a long duration of operation. So this is the aim and the focus, and of course it is important to keep in mind that this approach gives us the opportunity to consider that quality is what matters, not quantity. So the outcome is measured by the quality of our procedure to be able to detect the proper lymph node and not to show how many lymph nodes we are able to remove. This is not the case nowadays as it was the past decades.
Okay, thank you, Professor Daniilidis. Question for Professor Kalogiannidis. Could you gently repeat, specify something about the prognostic factors that characterize the risk group of patient with cervical cancer?
Well, Professor Giannini, actually, the factors that it is necessary to proceed with fertility sparing approach. This is the question, isn't
Yeah,
it?
yeah.
Okay. So it is, we can select all the group of patients independently of the histology, squamous as well, adenocarcinoma, because there was a little bit of debate concerning the adenocarcinoma. Now there is no debate for this type of histology. The second most critical it is that the tumor it must be less than 2 centimeters. The invasion of cervical stroma, it must be less than 10 millimeter, and it will be better. It is better to have negative lymphovascular involvement. However, as you can see as you have the opportunity to see in my presentation, both the society, the European and the American society, leave a free space concerning the fertility approach for patients with lymphovascular positive involvement.
Okay.
And of course, the precondition, it will be node negative.
Okay. So thank you so
These
much for
are
this.
the rules of the game.
Okay, thank you for this clarification. So one question for Professor Chatzistamatiou. Could you focus again about the fertility sparing surgery? Is it feasible in a recurrence of borderline ovarian tumors? Could you focus and specify some more content, please?
Yes, it is feasible. And there are guidelines on that, but there are careful oncological selection criteria regarding this, which are mainly about the correct identification of the stage of the disease. It is the most important thing is what I said before, that when we talk about stage 1, it should be stage 1. We have to very thoroughly investigate the peritoneal cavity and assess the disease as we should have. So it is feasible, and also it is feasible even after the second recurrence. But those guidelines are not ready yet. I think that they are underway by ESGO. And they probably will say that it is feasible under certain circumstances, even after second recurrence. But of course, another important thing is to evaluate the fertility, to evaluate the fertility potential of the woman. Because if we talk about women of older age, then we should be very cautious about suggesting suggesting fertility sparing for a second or a third time.
Thank you. Thank you. We have a question for Professor Daniilidis. Could you specify which are the most relevant current evidence about the use of sentinel lymph node technique in atypical hyperplasia? Because you talk about this topic at the end of the presentation, talking that we have a 2% of positivity, but could you focus this topic and give us some state of the art about the literature?
Yes, thank you very much. There is a big debate actually on this subject lately, because, and the reason we have had all this debate was because actually we see now that sentinel node technique is feasible. The risk of morbidity is minimal. It is comparable with just doing a simple hysterectomy. In this case, of course, obviously and logically, there has been a debate whether we should apply this procedure also for the atypical endometrial hyperplasia. Well, the evidence I have demonstrated meta-analysis published in Gynecological Cancer in 2024 with 3 studies and a total of more than 100 patients for each of them with atypical hyperplasia. We do know that the risk of endometrial cancer for this case is quite high, 20 to 30%. This is why we advocate hysterectomy. But according to these studies, for this type of cancers, which will be detected after the atypical endometrial hyperplasia initial pathology, the final conclusion of the endometrial cancer will be that the chances that we'll have a positive sentinel node is less than 2%. So this is why a routine sentinel node evaluation may not be necessary. It's not forbidden, though. It is the outcome of this meta-analysis says that it may not be necessary. So we have to, I think, according to my opinion, and this is what I will do, is to discuss this with our patients individually and take the decision, because, okay, less than 2% is low, but it's not zero. So I think it's logical to offer it, but to say from the literature that the risk of having something else is too low. And I think in the future, perhaps things will change again, and perhaps there will be, well, this is my opinion, there will be like an advice for when there isn't any risk for morbidity for the patient, perhaps it will be applied, but things are getting easier and easier. So I think that's my answer
Thank
to
you.
that.
It's clear. So not over treatment. And Professor Kalogiannidis, could you explain, or could you repeat for some of the audience, what is the optimal conservative approach for stage 1B2 cervical cancer? Because this is more difficult to understand than the very early stage. Please.
President Giannini, thank you very much for the question, because it was, let's say, the most critical point in my presentation. For 1B2, we can use 2 different approaches. The first is the upfront radical trachelectomy with precondition of negative pelvic nodes. This approach offered to us a recurrence rate less than 5%. However, the live birth after this approach, it is only 35–40%. The second approach, it is the neoadjuvant chemotherapy plus simple trachelectomy and, of course, the precondition of negative nodes of retroperitoneal space. By this, the recurrence rate is more than 10%, almost double from the previous approach. However, the live birth after this approach, it is almost 75%. The selection is yours.
Thank you. A fast question for Professor Chatzistamatiou. Is estrogen safe a hormonal replacement therapy in postmenopausal patient with both?
Well, the answer is yes. They are safe. They can be used. There have been very small studies suggesting an association between borderline ovarian tumors and oral contraceptives, particularly unopposed estrogen use, but those are not data on which we can rely to avoid the use of estrogen therapy, of hormone replacement therapy. In general, there are also contradicting results. There is a meta-analysis showing no effect on ovarian cancer in general with the use of HRT. So the answer is that HRT can be used, and actually it should be used when the symptoms are very pronounced. The menopausal symptoms are very pronounced, and particularly in women less than 45 years old. But this use should be done cautiously and under close surveillance.
Thank you so much. So I think 2 minutes for concluding. I would like to thanks, really, I would like to thanks the 3 speakers, very high level of presentation for hot topic in gynecological oncology. And these are all the perfect example of precision medicine and personalized therapy. So very, very modern and smart presentation. Thank you so much. And I would like to underline the relevance of this event, because this is a webinar of the European Society of Gynecology, but this is an event that was organized and performed together with the collaboration of the Obstetric and the Gynecological Society of Thessaloniki. And I would like to thank this society and the representative of this society. We will work together very soon for a very important event. So we will wait together for a very important scientific event. Thank you so much. And thank you, the audience, for being here. Thank you again for the organizer. Thank you.